think we may end up starting at the beginning. All right, so I'm going to take you through this very quickly. There we go.
We have a recording again. This is a different angle.
And let's go here. So this is the lung that's inflated back to 0 PEEP. Okay, I'm going to stop the video. So this lung looks reasonably homogeneously inflated on the first breath. Look what happens in the very next couple of breaths. After reducing PEEP, you can see here that the lung is again collapsed, and all the beneficial effects of the recruitment maneuver are gone. So I showed this movie because I think a video because it shows a number of things that I think are important. First of all, you could see when we talk about recruitment, this is what recruitment looks like. I mean, it's amplified here because this is an ex vivo lung. There's no chest wall. So when it collapses completely. There are a number of points that's different than human lungs in the ICU or in the OR, but they're still very similar. Secondly, you could see recruitment takes time. When we increase the PEEP, it took a number of breaths. Actually, in patients with disease, it actually takes much longer. It can take hours to recruit the lung. And the third point is that you could see when we decrease the PEEP that the lung de-recruited. So if you're using recruitment maneuvers, if you go back down to a low PEEP, the beneficial effect is lost pretty quickly. And I would guess fourth, you can see if you overexpend the lungs, that could lead to injury. You can't really see that from the video, but you can see that at low lung volumes, the lung opens and closes, and that can cause injury. So let's use that as a basis now for thinking about ventilator-induced lung injury. And there are a number of factors related to, there are a number of mechanisms that can cause ventilator-induced lung injury. One is called Barotrauma, which I'll talk about, Volutrauma due to overdistension, ARRD trauma, that's that ventilation at low lung volumes where you recruit and de-recruit the lung, Biotrauma, and there are other factors, and I'm not really going to talk about, that probably have a second-order effect on lung injury. So let's talk about barotrauma, which you've all heard of, and Volutrauma. So barotrauma really means gross air leaks and pneumothorax, things like that. And there was actually a couple Canadians, Macklin and Macklin, who did a lot of the great work on barotrauma. And what they realized that if you look at the alveolar region, it's in close apposition to the bronchovesicular sheath. And that if you get an increase in volume of the alveoli or an increase in pressure across this membrane, that could lead to a break in the membrane and cause gas to flow from the alveoli into the bronchovesicular sheath, travel proximately, and then out again to cause the mechanisms or the pneumothorax, subcutaneous emphysema, those things we see in patients with severe barotrauma. So that, I think, has been well known since at least when mechanical ventilation started, and I'm sure that case report I showed you from 1750, 1745, this is what he was thinking, that if you overinflate the lung, you can actually blow it up like a balloon and it breaks. But there's a little more subtle injury that can be caused by ventilation at high lung volumes, that of Volutrauma. And that was shown very nicely in a study by Webb and Tierney published 1974, a long time ago, in which they ventilated rat lungs with either peak inspiratory pressure of 14 or peak inspiratory pressure of 45. And you can see here, this is what the lung looked like grossly after an hour of ventilation. This is what it looks like grossly after an hour of ventilation with a high peak inspiratory pressure. Lung was overinflated. This lung looks almost like a liver. It's wet, edematous, very heavy, and these animals died. And I'll come back to what this middle lung is about a little later in a slide I'll show you. So they clearly showed that if you overventilate the lung, you can cause pulmonary edema, cause damage. So Didier Dreyfus and colleagues, actually from Paris, showed a number of years later, about 15 years later, that the key factor is the amount of lung stretch. So what they did was they took rats, they ventilated them with high pressure and high volume. By that I mean relatively high tidal volumes that led to high pressures in the lung, led to overdistension. They had a second group in which they put a band around the chest wall to stop the lung from expanding very much, but generated the same airway pressure in the lung. And what they found then, they ventilated for a couple of hours, and then they looked at wet to dry weight ratio, and they found that the high tidal volume group had an increase, you can see quite dramatic increase in wet to dry weight ratio, and the low tidal volume group with the bands around the chest wall had no increase. So what they coined the term Volutrauma to explain this injury, that lung is being overdistended. This is not surprising at all. This is taken from a study by Bauheis published in Nature in 1969. His interest, he wasn't interested in mechanical ventilation or ventilator-induced lung injury. What he was really interested in was musical instruments and what happens to what's the physiology of music playing when somebody plays musical instrument. Here you can see on the x-axis here what he did is he plotted pressure at the airway opening. On the y-axis he plotted lung volume. And you can see, let's take here number 1 is the oboe, that's shown here. You can see that the pressure generated is about 25 centimeters of water. Lung volume starts here, and over 30 seconds, that's the duration of blowing, the lung volume decreases and the pressure is 25. Look what happens with the trumpet player. The trumpet player blows for 5 seconds, volume decreases quickly. Look at the pressures. They can generate pressures of 150 centimeters of water. That's huge. You know, if you saw that number at the airway opening on a patient on a ventilator, you know that that patient is going to develop a pneumothorax on that breath. So why is it? Trumpet players blow the trumpet, you know, hundreds of times, thousands of times a day, every day of their lives. They don't get pneumothoraces on a regular basis. Why is that? Well, I think the reason is that it's related to the chest wall mechanics and respiratory system mechanics. Remember, to generate a high pressure like a trumpet player of 150 centimeters of water, the trumpet player, stresses their muscles. The muscles, the chest wall muscles, contract. That causes an increase in pressure, which is causes an increase in pressure in the pleural space. But the pressure across the lung is not very high. And that's the important pressure. The important pressure is the transpulmonary pressure in terms of injury. The transpulmonary pressure is not increased. And I'll show you that on this slide here. This is a simplified schematic of sort of the key pressures. Here you have the lung inside a chest wall. You have the airway pressure, which we often measure. You have the alveolar pressure, which we measure, and I'll talk about that in a moment, how we measure that. And then there's a pleural pressure. And the important pressure in terms of lung distension, lung injury at high lung volumes is the transpulmonary pressure, the pressure from here to here. So in situations where the chest wall is stiff, and I'll come back to this, where you have a very stiff chest wall, you may have high airway pressures, but you don't have high transpulmonary pressures. And that's the case of the trumpet player, where you don't have necessarily high transpulmonary pressures. So what do we do clinically? Well, how do we clinically assess the propensity, the likelihood of ventilator-induced lung injury? Well, we'd love to measure regional lung distension. That's really what we'd love to measure. Difficult to do in patients, and then difficult to know when there is overdistension. So what we often measure is pressures. And the easiest thing to measure is peak inspiratory pressure. And I think that that's useful, but you have to remember that peak inspiratory pressure doesn't necessarily tell you about lung distension for lots of reasons. One is there's the pressure that you're measuring at peak inspiration tells you about the flow resistive pressure and the elastic pressure. And so that takes into account the resistance of the endotracheal tube in the airways as well as the flow rate. So if you had a patient with a given size endotracheal tube, if you could instantly change that tracheal tube to a much, much smaller size, but you give the same tidal volume with each breath and the same flow rate, you could see that the pressure is going to be much higher because the resistance is higher. But that doesn't mean the patient's at more risk for developing ventilator-induced lung injury. The next pressure we often measure is the plateau pressure, and that's the pressure at the end of inspiration. The idea here is inspiration stops, you have no more flow, so you get rid of that. That's useful. So that's a little bit better because you get rid of the pressure drop across the airways, but you still have the problem, as I mentioned, of chest wall stiffness. So for example, if you have a patient with massive ascites, very massive ascites, that pressure is going to be high. But that doesn't mean the lung is being overdistended because the transpulmonary pressure is not increased. And we all see this. Again, if you have a patient with massive ascites, you look at the pressures and then you do a chest x-ray. On chest x-ray, the lungs look tiny, and yet the pressures are very, very high. So that's not the best pressure, but it's the one we often use. Probably the best pressure, and there's difficulties with this, is the transpulmonary pressure. because it tells you a little bit more about alveolar overdistension. And there are some studies in the literature, and people are starting to use it a little bit more. In terms of the absolute transpulmonary pressure, still difficult to measure that, even if you put in an esophageal balloon to measure pressure. But I think that's the better pressure. And the other advantage of the transpulmonary pressure, even if you measure pressure at the airway opening, let's say it's low, but the patient is breathing spontaneously and generates a large negative pleural pressure, you may have a low pressure at the airway opening, but the lung is overdistended, and that's what can lead to injury. So that's injury due to overdistension. As I mentioned a couple times, there's injury actually can be due to the lung collapsing and reopening, something we've called Adalectrauma. And here's a study that I'll just show you some results from about 20 years ago that we published in the American Review of Respiratory Disease. This was using an ex vivo lung model. Took the lungs out of rats, ventilated them, not perfused, just ventilated them. So we could, the reason for that I'll come to in a minute. And we had 4 groups. One group, I'll call it, it's actually number 4 here, control group. We kept the lungs inflated at a CPAP of 5 centimeters of water, no ventilation at all. That's sort of the control group. We then ventilated them with 0 PEEP, either PEEP of 4 or PEEP of greater than the inflection point that I showed you earlier. And we used a tidal volume of about 7 ml per kilo, relatively small. And then we looked at the pressure volume curve before and after these ventilatory patterns, as well as structural lung injury by pathology. So here's the control group that we just inflated at a CPAP of 15. And you can see the pre and the post pressure volume curve basically lie on top of one another. You can barely tell the difference between the two. Here's what happened with pressure when the PEEP levels were less than the inflection point, either 0 or 4 centimeters of water. You can see this is the pressure volume curve before, this one here with the closed circles, and this is what happens after just 2 hours of ventilations with the open triangles. You can see that there's a marked decrease in compliance. You know, for a given pressure, the volume is quite a bit lower, and this was true with PEEP of 4 or PEEP of 0 or PEEP of 4. And here's what happened when we used higher PEEP levels greater than inflection point. So in other words, relatively high PEEP levels, you can see that there was very little effect on, there's no effect essentially, on the pressure volume curve of the lung. We also, as I said, looked at a total lung injury score by pathology, control group, PEEP of 0, you can see a marked increase in total airway injury score. With PEEP of 4, this was decreased a little bit, and PEEP of 16, no airway injury score. So what's happening here is at very low lung volumes, the lung is collapsed, reopens with each breath, and that can cause injury. And I'm coming back now to that slide I showed you by Webb and Tierney. Remember I showed you peak inspiratory pressure of 14 and 45, huge difference with basically this one looking like a liver. Well, in that study, they also had a peak inspiratory pressure of 45 in one group, but you can see this looks quite a bit different than this lung. And the reason for that was in this one they used PEEP of 10 centimeters of water. This they used the PEEP of 0. So this may be related to Adalectrauma. There may be other mechanisms that may explain the decrease in lung injury due to the fact that you're still overinflating the lung, but now protecting it. So if we sort of summarize some of the physical factors causing ventilator-induced lung injury, there's injury can be caused by ventilation at low lung volumes, Adalectrauma, lungs opening, there can be closing, there are effects on surfactant. There's also injury at high lung volumes, gross barotrauma, and increased alveolar capillary permeability due to the ventilation at high lung volumes. And there's also some evidence, not as yet published, that maybe the change in pressure between inspiration and expiration is the key driver of what's causing lung injury. I'm not going to talk about that any further. Another type of injury that's more subtle than these types of injury is something called, we've called biotrauma. And we published on this about 15 years ago in the Journal of Clinical Investigation, a study looking at not just looking at some of the biochemical implications of the biophysical trauma. So a hypothesis was that when we used injurious forms of ventilation, which I showed you previously, that this could lead to an increase in inflammatory cytokines. So physical forces could lead to biochemical output. And for this, we use that isolated rat lung model, the video I showed you, for a number of reasons. I won't go into the details. And I won't go into the details here, but we use 4 ventilatory strategies. And when we looked at, after 2 hours of ventilation, we looked at a number of cytokines. I'm just showing you tumor necrosis factor alpha, a key mediator in the sepsis cascade. And you can see that under control conditions, lung lavage, cytokines very low. If we ventilated with high tidal volume, stretch the lung a lot, let it collapse completely, about a 50-fold increase, there's a break in the axis here, 50-fold increase in TNF alpha. So pretty marked increase. So that showed that ventilation can lead to release of mediators into the lung, which could potentially cause damage there. But I think what's most important is the potential systemic consequences of biotrauma, what we call biotrauma. Why is that? Well, if we stand back, think about the lung is connected via tube to the ventilator. That's really a system, and that can be a source of, that can be a very pro-inflammatory system, in fact. The reason is that the lung is a pretty unique organ. First of all, virtually all of the circulation goes through the lung. It's got this huge vascular bed, and there's many, many neutrophils, as you know, just marginated in the lung, waiting to be activated. And they're there for a good purpose, to try and prevent the problems if you inhale bacteria or viruses, that those cells are there ready to act. But the lung also has a huge surface area, that of almost a tennis court, and many pathogens can enter. And it's an actively metabolically active organ. If you look at the epithelium, endothelium, those can produce lots of cytokines themselves. We thought that they were passive in the past, but they can produce lots of mediators, not just cytokines, various mediators. So the lung is sitting duck, if you like, to be a source of systemic inflammation. So this is a study published a number of years ago, looking at what happens now to cytokines in the blood, not just in the lung, with an in vivo model. So this is, I think, a clinically relevant model. You put acid into the lung of animals, of rats. You ventilate them with different ventilatory strategies, shown here. And then we measured cytokine levels now in the blood, not just in the lavage. And here's the blood levels of various of TNF. This is time on the x-axis. And on the y-axis is TNF alpha. You can see that there's most of the ventilatory groups had no or minor increases in TNF over time. One group had a marked increase in TNF over time. That was this group here with 0 PEEP and overinflation. So atelectasis, atelectrauma, and overdistension could lead to the release of mediators. Now they get into the systemic circulation. So now we're talking about something completely different, not just what's happening in the lung, but an impact on the circulation, and therefore potentially an impact on other organs. And we looked at that a few years ago in a model that was published in JAMA. Model was anesthetized rabbits using acid aspiration. And what we wanted to see was, what's the effect of ventilator-induced lung injury, not just on the lung, but on systemic various organs. And so we took this model, ventilated the animals either with an injurious ventilatory strategy or with a non-injurious ventilatory strategy. We chose the strategy so the mean airway pressure was the same, so the hemodynamics would be the same, and then made a number of measurements over 8 hours, including apoptosis, programmed cell death, and a number of other measurements. So here is the studies from, first of all, the kidney. Here's the non-injurious ventilatory strategy. Here's the injurious strategy. These arrows are pointing to apoptotic cells that are going apoptosis, so programmed cell death. You can see that there's virtually no arrows here, and there are some arrows here, non-injurious, injurious ventilatory strategy. So just to summarize what we're doing here, we're taking lungs, we're creating injury in the lung, we're ventilating them with 2 different ventilatory strategies. Blood pressure is the same in both strategies. Mean airway pressure is the same in both strategies. And yet we're finding something happening in the kidneys in one case and not happening in the kidneys in the other case. So how is that? And the same in the small intestine, in the villi, but not in the crypts, the injurious ventilatory strategy. And we summarize this. Here's the apoptotic index. You can see the kidney, that there's a marked increase in the apoptotic index. In the villi, there's an increase, not in the crypts. So what we're suggesting here is that, these mediators that get into the circulation can have an impact on other organs. And that's important because we know that, for example, with an ARDS, our patients don't die of respiratory failure usually. They die of multiple system organ failure. So this here is a potential mechanism to explain that. Maybe it's something we've been doing with the ventilator. And there's more that we can do, or bad that we can do with the ventilator. This is a study from Verbrugge, published in 1998. The objective here, they set out to examine the effect of peak inspiratory pressure and PEEP on bacteremia. So they took rats, instilled Klebsiella, and then ventilated them with 4 strategies. And this is the peak inspiratory pressure of 13, PEEP of 3, 13-0, 30-10, and 30-0. They did that for a few hours, starting 22 hours after inoculating the lungs. And then they did blood cultures of these animals. And here's what they found. This is the number of animals with bacteremia. With the 13/3 strategy, a couple of animals, 13/0, none, 30/10, a couple of animals, 30/0, marked increase in animals with bacteremia. So again, the ventilatory strategy has an impact not just on what we're doing in the lung, but can cause bacteremia. Well, if you have patients with pneumonia, and if you have patients with bacteria in the lung, which virtually all our patients can get in the ICU, that can lead to sepsis and multiple system organ failure. So, is this concept of biotrauma important? I mean, what I've shown you is work in animal studies, and I guess it's important for getting papers published, but is it important clinically? And to be quite honest, we don't know for sure yet whether it is or isn't. But I would say it probably is, based on the hypothesis I just described. We have mechanical ventilation. We've known for many years that it can cause biophysical injury. It can lead to increased alveolar capillary permeability, effects on cardiac output, things that have been known for 50-plus years. We also know that it can lead to more subtle injury, biochemical injury, biotrauma, with release of mediators in the lung. This can recruit neutrophils to the lung, release more mediators. These mediators can potentially get into the systemic circulation, lead to distal organ dysfunction, and potentially be the reason why patients die, patients with ARDS and others die. So that's the hypothesis. But as I said, is it real? Is it important? Well, I think it's important for a couple of reasons. One is biotrauma does occur in humans, not just in animals. This is a study we did. Marco Ranieri was the first author a number of years ago, in which we took patients with ARDS, ventilated them with a control strategy, ventilatory strategy, which was common at the time, or a more lung protective strategy using higher PEEP and smaller tidal volumes. This is bronchoalveolar lavage fluid at 0, 24, and 36 hours. And you can see this is the control group. There was an increase in TNF over time in the BAL. In the lung protective strategy, there was a decrease in time. Now, that doesn't look like a big decrease, but this is a log plot. That's times 10, 10 to the third, 10 to the fifth. So that's a pretty big decrease compared to this increase. And this was true in the plasma as well for TNF, a marked increase in plasma TNF, and a not quite statistically significant, but a decrease in the lung protective strategy. So this occurs in patients. This is now patients with ARDS. Now, we weren't the only ones to show this. This is published a few years later by Stuber and colleagues looking at patients. And they did a very nice study. And I think what was nice about it is the time frame that they used. So they used a lung protective strategy. They then used a lower PEEP and a somewhat higher tidal volume. They did this only for 6 hours. And you can see that after the first hour, after 1 hour of less protective strategy, marked increase in IL-6 that decreased when they put the patient back on a lung protective strategy. So the important point here was it occurs in humans, but also that this can occur very quickly. So even a short period of time and an injurious ventilatory strategy can be bad for your patients. Secondly, why this I think is important is it might explain the increased mortality in ventilated ARDS patients. I showed you this. This is one of my first slides to show you the decrease in mortality in the ARDS study published in 2000. And so the question is, why did this group with the smaller tidal volume, why did they do better? What was it about that group? Well, what's the mechanism for the decrease in mortality? Well, it turns out it wasn't related to oxygenation. In fact, this group here, 60 ml per kilo, had somewhat worse oxygenation at the end of the first 2 to 3 days than this group here. It wasn't related to barotrauma. There was a 1% difference in barotrauma. That wasn't it. And what the investigators suggested was maybe this is due to essentially biotrauma. And a few years later, they published a paper, Polly Parsons was the first author, in which they looked at the reduction in various cytokines in the 6 ml per kilo group versus the 12 ml per kilo group in the first 3 days. And you can see here's the percent reduction in IL-6, IL-8, IL-10. These are statistically significant. Not huge differences, but it doesn't tell you that some patients had big differences, others none. So they suggested that this might be the mechanism for the decreased mortality. There's other reasons, I think, in terms of biotrauma. We might be able to target biotrauma in the future, but I don't have time to go into that because Antonio is just standing up, so I'll then therefore conclude. So there's multiple mechanisms for development of ventilator-induced lung injury. I've talked about each of these: barotrauma, volutrauma, Airleaks trauma, and biotrauma. And I think that it's useful to understand what those mechanisms are, because we certainly don't have all the answers for how to ventilate patients, but I think when you're taking care of patients at the bedside, it is important to think about this. Just a short period of time with injurious ventilatory strategies can be harmful to your patients. It might be why maybe we've been killing our patients by using inappropriate tidal volumes. And I'll just give you one anecdote. If you look back, Roger Bone, famous pulmonary intensive care physician who died a number of years ago, had an abstract in about 1980 on barotrauma in patients with ARDS. And he had, in that paper, the percentage of patients who had air leaks sufficient to need chest tubes was like about 48%. Half the patients required chest tubes. Tidal volumes they were using was about 18 ml per kilo. So now I think we've clearly changed that. And I think that mortality is decreasing. So there's various forms of lung protective strategy. When I made this slide, I think we can take high-frequency ventilation off that, given the couple of recent trials. And in the future, I didn't have time to talk about that. Maybe we will be using anti-mediator therapies. Maybe we'll be using more ECMO, a number of potential ways to try and mitigate ventilator-induced lung injury. Thank you very much, and I'd be happy to take any questions.
Thank you, Arthur. Any question, or please?
Why does the trumpet player not get mediastinal emphysema?
So the question is, why does a trumpet player not get mediastinal emphysema? And I think it's related to the fact that picture I showed you from about the 1940s, looking at the mechanisms of barotrauma, it's the pressure across the alveoli to the bronchovesicular sheath. And both of those are inside the chest wall. So that the chest wall muscles generate a large pressure. The pressure, so there isn't much of a pressure difference across there. And it's that pressure difference that's important. It's the stretch that's important.
When you get close to the neck, don't you think there when you're getting close to the neck with these high intrathoracic pressures and above, let's say, the sternum, you have normal pressure.
Yeah. So there is a junction that there is a high pressure, not a high pressure, but certainly in the lung, because we're talking about it's a transpulmonary pressure, and there is no marked increase in transpulmonary pressure.
Thank you.
I can understand the importance of all the traumas you talked about in patients with ARDS or who already have an acute lung injury. Are they the tidal volumes? Are they important in patients with normal lungs, for example, in operative theaters?
Yeah, that's a very good question. There's been a number of studies addressing this, and based on these mechanisms. Look at you have someone who's running the marathon. It takes very large tidal volumes with each breath, and they don't get ventilator-induced lung injury. So, having said that, though, there's studies that suggest that the concepts we're talking about are actually very important. So there's a couple of studies that have looked at historical databases and suggested that normal patients, they're ventilated in the ICU, so are they really normal? But if those ones who get larger tidal volumes early actually are the ones who go on to develop ARDS. And there's actually a randomized controlled trial led from Holland, that Marcus Schultz was the senior author on, that if you randomize patients and use smaller tidal volumes versus higher tidal volumes in patients without ARDS to start, the ones who use higher tidal volumes actually go on to develop some ventilator-induced lung injury, ARDS. So in fact, you probably should use lung protection both in the ICU, even in relatively normal lungs, and maybe in the OR. The issue here is you have to be very careful. If you use too small tidal volumes and get atelectasis, you may actually cause more harm than good. So I think that, yeah, the concepts are correct, that you certainly should use a strategy that's lung protective. And I think using somewhat smaller tidal volumes with a little bit higher PEEP is probably the right thing to do. We don't have the answer for sure, but there's both epidemiologic data and a randomized controlled trial that may be the case, in fact, that you should be careful even in patients who don't have ARDS.
Okay, thank you very much, Art. We proceed with the next